You know, usually when we talk about a medical diagnosis, there's this expectation of like mechanical precision.
Right, yeah, a very clear-cut answer.
Exactly. You break your arm, the x-ray shows this jagged white line, and the doctor just points at the film and says, well, there it is. That's the problem.
It's a very comforting binary, I mean, for both the patient and the doctor. The pathology is visible, it's easily categorized, and the solution setting the bone is mechanically straightforward.
But step into the world of oncology, and specifically the underlying biology of cancer, and suddenly that x-ray machine is broken. We're looking at a diagnostic landscape that is incredibly murky.
Murky is probably an understatement.
Truly. And for those of you listening, whether you're a medical student cramming for your oncology boards, maybe a young professional navigating your first clinical rotations, or just, an intensely curious learner trying to understand human biology, you know exactly how complex this landscape can get.
Oh, absolutely.
Today, we are wading right into those muddy waters. We are doing a deep dive into excerpts from a highly controversial book. It's called Transition from Crime to Care in Oncology, a critical review of current cancer research and its applications.
A very bold title.
Yeah, it is. It's written by Dr. Mohammed A. Nezami, who's an MD. He previously worked in the California corrections system and now operates in the integrative oncology space.
I think it is absolutely vital to establish right at the top what we're actually doing here today.
Right.
Because Dr. Nezami makes some extremely aggressive critiques of the mainstream oncology and pharmaceutical industries. I mean, he promotes alternative, highly customized epigenetic therapies that fall far outside standard of care protocols.
Yeah, and to be perfectly clear to you listening, our mission today is purely educational. We are not endorsing or validating Dr. Nezami's views.
Right, no endorsements.
We are not taking sides against mainstream medicine, the FDA, or standard clinical oncology. Our goal is simply to impartially map out his theories so you can understand the mechanics of this alternative paradigm.
Because you really need the scientific vocabulary to understand what he's arguing, as it challenges some very foundational concepts you'll encounter in medicine.
So let's unpack this. He argues that mainstream medicine falsely equates the tumor with the cancer itself.
Right, which is a wild concept at first glance.
Yeah. In his paradigm, they are two entirely different biological entities. The tumor is just a collection of differentiated daughter cells. It's just the symptom. The actual cancer, the root cause, consists of the cancer stem cells.
To give you a sense of scale from the text, Nezami notes that it takes a minimum of 500 stem cells in a local tissue area to produce a detectable breast cancer colony.
500, that's it.
That's it. Those 500 stem cells act as the factory, pumping out millions of differentiated daughter cells.
Okay, so the mass we see on the scan is just the output.
Exactly.
Sure.
And conventional therapies like standard cytotoxic chemotherapy and targeted radiation, they're incredibly effective at wiping out those millions of daughter cells.
Right, the tumor shrinks.
Yeah, the radiological scan comes back clean. Everyone celebrates.
But the factory's still there.
The factory is untouched.
So if I'm visualizing this, if the tumor is just differentiated daughter cells, then a surgical excision or localized radiation is essentially just clearing out the downstream symptom.
Yes. And Nezami goes a step further, claiming that traditional cytotoxic therapies actually make the underlying disease worse.
Wait, worse? How?
He argues these treatments induce stem cell plasticity. By destroying the bulk of the tumor rapidly, you increase intratumoral hypoxia.
Which means you're starving the microenvironment of oxygen.
Right. And this hypoxic stress triggers deep survival mechanisms in those remaining stem cells. It actively selects for highly resistant clones, particularly the ones harboring mutations in the TP53 gene.
And TP53 is normally responsible for tumor suppression, right?
Exactly. You're effectively training the worst cells to survive.
So, let me try an analogy here. Conventional treatment, in his view, is like repeatedly mowing over a patch of aggressive weeds.
I like that, yeah.
It looks clean on the surface for a while. You look out at the lawn and think, well, the weeds are gone. But because you haven't extracted the root system, the stem cells, it's guaranteed to grow back.
It's inevitable.
And according to his theory, because you've sprayed toxic weed killer and stressed the soil, the roots dig deeper, and the weeds that eventually sprout are completely resistant to whatever chemical you just used.
That analogy aligns beautifully with how Nezami explains the high recurrence rates patients face. Even after achieving a so-called complete response to traditional chemo, the root system remains.
So how does he actually monitor that clinically? I mean, if he isn't just looking for tumor shrinkage on a PET scan.
He measures stemness, He looks for specific blood markers, prominently a gene called c-Myc.
Okay, just to ground that for our learners, c-Myc is a regulator gene. It codes for a transcription factor that essentially drives cell division.
Right. In a healthy cell, it's tightly controlled.
But when it's overexpressed, you get runaway cellular growth.
Exactly. So he uses c-Myc levels to track these elusive circulating tumor cells, or CTCs, and progenitor cells in the bloodstream.
So if the c-Myc levels remain elevated, the cancer stem cell factory is still operating.
Yes, completely, regardless of what the imaging shows.
That is a fundamental flip in how we measure success in clinical oncology. But that begs a massive biological question.
Which is?
If the genetic mutations of the tumor, the actual mass of daughter cells, or just downstream symptoms, who handed the stem cell factory the blueprints to go rogue in the first place? Like, what is the upstream cause?
And this brings us to what is arguably the most radical part of his thesis. Nezami theorizes that epigenetic influence entirely dictates genetic mutations.
Epigenetics being the environment surrounding the DNA, right?
Yeah.
The chemical signaling, cellular context, toxins, stress.
Yes, exactly. So it's not the hardware, it's the software telling the hardware to physically break.
Right.
He asserts there is virtually no dividing line between epigenomics and genomics, except for the element of time. The text uses a very specific phrase. Methylation is mutation.
Okay, let's break that down. Methylation being the epigenetic process where chemical groups attach to the DNA molecule. They don't change the sequence of the letters, the A's, C's, T's, and G's, but they act like switches.
Right, turning genes violently on or completely off.
So Nezami argues that a permanent genetic mutation is just the eventual physical manifestation of an epigenetic variance that started long before.
That's his claim. And the text uses the BRCA mutation as a primary example.
Oh, that's interesting because mainstream medicine views a BRCA mutation as the starting point, right?
Yeah.
The inherited trigger for breast or ovarian cancer.
Exactly. But Nezami claims the BRCA mutation is not the initial trigger, but a byproduct of long-standing epigenetic disruption.
And he provides some staggering historical statistics to back this up.
Yeah.
He points out that the incidence of breast cancer in BRCA-positive individuals was around 26% in the 1940s.
Only 26%.
Yeah. And today, that incidence has jumped to 72%.
His argument there is that the DNA sequence of the BRCA gene itself hasn't radically mutated across the entire population in just 80 years. I mean, that's way too fast for traditional evolutionary genetics.
Right, that makes sense.
What has changed is the epigenetic environment, diet, industrial chemicals, chronic stress. He says that environmental degradation over the last 8 decades has forced that gene to express as cancer at a massively accelerated rate.
Okay, I have to push back here just to make sure we're analyzing this critically.
Go for it.
If we connect this to the bigger picture, he is suggesting that even highly penetrant germline mutations, the genetic traits passed down through families that we consider ticking time bombs, are just downstream effects.
Yeah.
So for the medical students listening, how does he explain inherited early onset cancers in young adults? I mean, a 20-year-old literally hasn't been alive long enough to accumulate decades of environmental epigenetic damage.
It's a great question. To explain early onset and inherited cancers, Nezami introduces the concept of constitutional epimutations.
Constitutional epimutations. What does that mean in practice?
It means the epigenetic software bug is built into their baseline biology from birth. It's transgenerational.
Oh, wow.
Yeah. He cites cases of early onset colon cancer. Usually a clinician looks for a genetic mutation, like in Lynch syndrome, but Nezami points to cases driven by constitutional MLH1 epimutations.
Let's define that mechanism for everyone. The MLH1 gene's promoter region is hypermethylated. Basically, a chemical padlock is placed on the gene that normally handles DNA mismatch repair, and it's just turned off.
Exactly. And this epigenetic silencing is transmitted through the maternal germline without any apparent alteration to the DNA sequence itself.
So the mother passes down the faulty software, not a broken hard drive.
Perfect way to put it. And he extends this to lung cancer as well. It explains why non-smokers develop lung cancer with KRAS mutations, which is classically a hallmark of direct smoking exposure.
Yeah, how does a non-smoker get a smoker's mutation?
Nezami argues this is due to epigenetic disruptions caused by their parents or grandparents smoking.
Are you serious? Their grandparents?
Yes. The environmental damage inhibited histone demethylases generations ago. That epigenetic memory is passed down, sometimes up to 10 generations, eventually solidifying into a physical KRAS mutation in an individual who has never touched a cigarette.
So the epigenetic energy, as he frames it, eventually materializes into physical genetic material.
Yeah.
I mean, it's a fascinating paradigm, but honestly, it's also terrifying for a patient.
Oh, deeply terrifying.
Because if the underlying driver of cancer is this invisible transgenerational environmental force, how does a patient mentally navigate that, especially when they're sitting in a sterile clinical room receiving a life-altering diagnosis?
That psychological aspect actually bridges the biology with human behavior, and it's central to Nezami's systemic critique of modern medicine. He argues that the medical system entirely ignores the physiological chain reaction that occurs the moment a diagnosis is delivered.
We have the shock of it.
Right. Hearing the words, "you have cancer," triggers the paleocortex.
The primitive animal part of the brain, the fight-or-flight response.
Exactly. Cortisol floods the system, sympathetic drive takes over, and rational thought is chemically suppressed.
So when the paleocortex is triggered by a massive stressor, it basically hijacks the neocortex,
Mm.
our logical, higher-level decision-making center. Patients are just thrown into sheer survival mode.
And Nezami uses a really poignant analogy here. He talks about a schoolgirl walking across a snow-covered playground. The teacher tells the kids to walk in a perfectly straight line to a tree on the other side.
Okay.
Every kid ends up making a zigzag path because they are staring down at their feet, trying to force each individual step to be perfectly straight.
But one girl makes a perfect line because she kept her eyes fixed entirely on the tree, her destination, and ignored the granular details of her feet.
Exactly. It's a powerful metaphor for his philosophy of care. Nezami argues that the sheer terror of the diagnosis forces patients to stare at their feet. They get consumed by the daily panic, the survival statistics, the immediate fear of death.
And they lose sight of the tree, their destiny, their broader life goals, their quality of life.
Right. And because that paleocortex fear prevents logical focus, he claims patients surrender incredibly quickly to standard of care treatments without critically evaluating the long-term toxicity or the true clinical efficacy of what they're agreeing to.
No, standard oncology would likely argue they rely on massive randomized controlled trials to establish these protocols specifically to prevent irrational emotional decisions.
That is the standard defense, yes.
So what does this mean for the industry, according to Nezami? If patients are making rapid fear-based decisions while their neocortex is hijacked, who does he believe is benefiting?
Well, this is where his claims become deeply, deeply critical of the medical establishment. He argues that the current system capitalizes on this fear. He goes so far as to claim that legitimate, properly prescribed, evidence-based medical care is the third leading cause of death in the United States.
I mean, that is a staggering accusation.
It is. He accuses regulatory bodies, specifically the FDA, of fast-tracking what he calls toxic placebos.
Toxic placebos. Can you give an example from the text?
He gives the example of the drug Stivarga, which is approved for metastatic colorectal cancer. According to Nezami's interpretation of the clinical data, the drug carries a 40% severe toxicity rate, but an efficacy rate of only 0.4%.
Wait, 0.4% efficacy. What does that even translate to in actual patient survival?
In the specific trial he cites, it extended overall survival by a median of merely 9 days.
9 days. 9 days of life gained for a 40% chance of enduring severe quality of life destroying toxicity.
Yes.
I can see why he views that as a failure, even if standard care considers that small margin statistically significant enough for approval.
His argument is that the oncology industry is financially incentivized by the quantity of care, not the quality of the patient's outcome. He points to the practice of prescribing massively expensive drug combinations.
Like pairing the anti-angiogenic drug Avastin with PD-1 inhibitors for metastatic disease.
Exactly. He views this as a financial model that maximizes pharmaceutical revenue while often failing to provide durable, long-term survival benefits. He genuinely believes the system rewards prescribing over healing.
So he completely rejects the standard pharmacological approach. He rejects the traditional metrics of clinical trials that just look at tumor shrinkage, viewing the entire mainstream model as, well, financially toxic and biologically backwards.
Right, completely throws it out.
But here's where it gets really interesting. Since he rejects all of that, what exactly does he do in his own clinic? I mean, if you aren't trying to cut it out, burn it out, or poison the daughter cells, how do you target an epigenetic software bug?
So his clinical approach relies heavily on off-label drug use and precision application. He takes existing medications, drugs that are FDA approved for entirely different conditions, and repurposes them for their secondary epigenetic or metabolic side effects.
Okay, let's give our medical learners some specific examples of what he is prescribing and, more importantly, the mechanisms of how they actually work.
Sure. One major strategy involves senolytics or anti-aging applications. As we discussed earlier, traditional chemotherapy accelerates cellular aging, creating senescent cells.
Zombie cells.
Exactly. They stop dividing, but they refuse to undergo apoptosis-programmed cell death. Instead, they just sit there and secrete highly inflammatory proteins that fuel cancer recurrence.
And Nezami uses targeted drugs like dasatinib, leukemia drug, or imatinib, to clear out these senescent cells.
Yes.
Which makes sense biologically because those drugs are typically used to interrupt survival pathways in blood cancers. So he's borrowing that mechanism to essentially force these zombie cells to finally undergo apoptosis.
He targets specific anti-apoptotic pathways, prominently PI3KCA and HIF.
Let's clarify those for the learners really quick.
Yeah.
PI3KCA is a major signaling pathway that regulates cell growth and survival. If it's mutated or overactive, the cell simply refuses to die. An HIF hypoxia-inducible factor is essentially the cell's emergency oxygen sensor. When a tumor is starved of oxygen, HIF kicks in to keep it alive by building new blood vessels. So Nezami is trying to turn off those exact survival switches.
What's also fascinating is that he notes imatinib's efficacy isn't just about targeting kinases. It's heavily tied to its glycolytic activity.
Aiming.
It fundamentally shifts the metabolic state of the cell, making the environment hostile to the cancer's preferred energy source.
Okay, so clearing out the senescent zombie cells handles the inflammatory environment, but that still leaves the actual factory, the cancer stem cells. How does he shut down production?
This leads to his use of teratogens.
Wow, teratogens.
Yeah, a teratogen is an agent that causes malformation of an embryo. They are highly dangerous in pregnancy. In agriculture, livestock that graze on teratogenic plants suffer reproductive failure and severe fetal deformities.
So why on earth would he use them?
Well, Nezami hypothesized that you could use homeopathic doses, microdoses of these teratogens to intentionally attack the reproductive capabilities of cancer stem cells.
Oh, because they affect the hedgehog pathway.
Yes, exactly.
In a developing embryo, the hedgehog pathway acts like a master blueprint, telling cells exactly where to go and what to become. Cancer stem cells hijack this exact same pathway to endlessly reproduce.
Right. And Nezami believes that by introducing microdoses of a teratogen, you scramble that blueprint. You effectively cause birth defects in the cancer stem cell's replication process, rendering it sterile.
That is incredibly clever. He cites using drugs like Glasgib, right?
Yes, which interacts directly with the hedgehog pathway, specifically to target the stemness of leukemias. It's a radical repurposing of a dangerous mechanism.
And he also relies on broader off-label repurposing to change the tumor environment. For example, treating high-grade neuroendocrine tumors with topoisomerase II inhibitors.
Right. And topoisomerase II being the enzyme that manages DNA tangles during cellular replication. Inhibiting it causes fatal DNA breaks in rapidly dividing cells.
Right. And in breast cancer, instead of hitting the patient with maximum tolerated doses of chemotherapy, he advocates for low-dose metronomic Cytoxan combined with letrozole, which is an aromatase inhibitor.
Yeah, letrozole blocks estrogen production, which deprives hormone receptor-positive breast cancers of their fuel.
But why pair it with a low continuous dose of chemo instead of the standard high dose?
Because the goal is different. A high dose seeks a cytotoxic kill, destroying the massive volume of daughter cells.
Right.
A low continuous metronomic dose is designed to inhibit angiogenesis. It starves the tumor of its blood supply constantly over time without completely destroying the patient's immune system in the process.
Listening to this, it sounds less like a standardized medical protocol and more like an incredibly intricate, high-stakes biological puzzle.
Yeah.
I mean, it relies heavily on the physician's individual clinical judgment to adapt continuously.
He openly admits that. He uses dynamic monitoring, relying on liquid biopsies.
Oh, so instead of waiting months for a P scan.
Right. He measures circulating tumor DNA or cDNA and microRNAs in the blood to track the epigenetic shifts in real time. If the markers change, the treatment changes that very day.
It is the absolute antithesis of a static, one-size-fits-all protocol.
Absolutely. And his ultimate defense of this highly personalized approach is that it prioritizes the quality of life. It's about reducing the stemness of the cancer cells to achieve a durable remission rather than just chasing tumor shrinkage at the absolute cost of the patient's immune system.
That is the core of his clinical philosophy, isn't it? to treat the cancer without destroying the host.
Exactly.
Okay, let's take a breath and recap this journey, because we have covered a massive amount of dense material today. We've explored Dr. Nezami's highly controversial biological paradigm, the idea that tumors are merely the differentiated symptoms of elusive cancer stem cells. We unpacked his hypothesis that epigenetic software drives genetic hardware, meaning environmental factors over generations eventually manifest as physical mutations. We navigated his systemic critique of standard oncology's financial models and reliance on paleocortex fear.
And finally, we looked at his clinical playbook, using off-label senolytics to induce apoptosis and teratogens to scramble the hedgehog pathway of cancer stem cells.
Yeah. And for the medical students and young professionals listening, it's vital to test your comprehension of these alternative models, if only to understand the breadth of theories you will encounter in practice.
Definitely.
So here's a quick review exercise for you. Based on Dr. Nezami's theories discussed today, if a patient presents with early-onset colorectal cancer, what specific epigenetic marker might you investigate in their family lineage? And based on his paradigm, why does Nezami argue that traditional cytotoxic chemotherapy might fail to prevent a recurrence in this specific patient? I'll give you a quick hint to chew on. Remember the maternal germline and the software bug we discussed? That's the constitutional MLH1 epimutation, where the promoter region is locked down.
And as for the chemo,
think about the factory in the daughter cells. The chemo wipes out the differentiated cells, but leaves the underlying stem cells, causing hypoxic stress that forces the remaining cells to mutate and come back stronger.
it's an excellent thought exercise in applying a completely different biological framework to a standard clinical presentation.
It really is. And to leave you all with one final provocative thought to mull over on your commute or your next walk, Nezami frequently references Einstein's famous equation, E mc phi crown.
Oh, yeah.
That equation proves that energy and mass are fundamentally interchangeable. There are two sides of the same coin. Nezami applies this directly to human biology. He claims that epigenetic energy, the invisible environmental influences, the stress, the cellular signals, eventually solidifies into genetic mass, like a physical, tangible DNA mutation.
It's a profound way to look at it.
Right. So if we accept that premise even for a moment, what happens if we completely stop viewing cancer as a fixed genetic destination, a broken piece of biological hardware, and start treating it as a reversible energetic process?
If the equation goes both ways, it completely reframes what healing could look like.
It really does. Thank you for joining us on this deep dive into the complex waters of alternative oncology. Keep questioning the paradigms, keep learning the mechanisms behind the medicine, and remember to keep your eyes on the tree, not just your feet. We'll see you next time.